Welcome to ChiroSphere, where we talk about all things chiropractic and some things not so chiropractic. I'm Dr. Ray Foxworth, your host for ChiroSphere and CEO of ChiroHealth USA, the network that works for chiropractic. Today on ChiroSphere, we're joined by someone who has become a go-to expert for some of the toughest cases in chiropractic and sports medicine, Dr. Ben Fergus. A graduate of National University of Health Sciences, Dr. Fergus is the founder and clinic director of Cornerstone Health, where he specializes in the evaluation and treatment of chronic and complex conditions, advanced biomechanics, and athletic performance. He's also the founder and head instructor for the Global GRIP approach, that's GRIP, an innovative framework for examination, rehabilitation, and injury prevention taught to clinicians around the world. Dr. Fergus made history as the first physician in Illinois to become a certified dynamic neuromuscular stabilization practitioner after extensive training at Model Hospital in Prague. His work spans clinical care, international teaching, and consulting for collegiate, professional, and even Olympic athletes. Thanks for being with us, Dr. Ben.
Thanks for having me. I'm excited to chat with you.
I love hearing about chiropractic journeys. I'm a second generation chiropractor. My mom and dad were both chiropractors, and ironically, they never pushed, encouraged, or suggested I go to chiropractic college. So I've got my journey, which was kind of atypical for a chiropractic kid. What led you to chiropractic? What initially drew you to the profession?
Yeah, well, a couple things early on. I think I was always interested in doing something that helped people directly, and I wasn't sure what that was. I was interested in the arts. I was interested in, sciences, but I wasn't sure exactly what my avenue would be. But something really interesting happened when I was growing up. My father was a home builder. He had a crew that would build houses, and in the summers, my brothers and I would work with him. And in a really busy summer, we'd get going and we'd look around, and the guys were looking a little beat up and worn down and bent over. And he did something really special. He would get everybody in the trucks on a lunch break and drive to his friend's chiropractic office. And I'd watch everybody kind of walk in, bent over. And 30 minutes later, they'd all kind of walk out in a line, standing upright and feeling good. And that always stuck with me, just the
Wow.
idea that there's something in healthcare with minimal invasiveness that could lead to almost immediate change in the way somebody felt. So that was like always in my mind, and it was kind of
Awesome.
cool to observe that.
Yeah.
And then, of course, I saw the chiropractor for various sports injuries and backaches and all of that. So I was always around it. And when it came to choose a profession to get into to help people, I thought it had the combination of the best scope of things I was interested in, paired with the least invasive approach of day-to-day working. And that really appealed to me.
It'd really be interesting to see what would happen if more employers integrated chiropractic like your dad did just into their weekly routine.
Right.
Probably have a lot less workers' comp claims and injuries and more people showing up to work and
Yeah. Higher
get
satisfaction, I think.
yeah, no doubt.
Well, I think we see that in our practice, and I don't know what your practice setting's like, but staff love getting care at chiropractic offices. So can only imagine how other professions who aren't around it all the time would benefit from it.
No doubt. So what led to your focus on chronic pain and complex case management? Because
Yeah.
not everybody goes there.
Yeah, I think it was a combination of assessing where a need was, and then also what ended up just being a good business move overall. So I grew up in a somewhat rural setting in the Midwest, and I had many family members, including, immediate family members who have had some pretty chronic musculoskeletal issues that went through the typical route of try a couple things that were accessible to them, like massage, PT, chiropractic, maybe not get the best results. So then they jump into the allopathic pathway, go through hospital care, and some of them get good results, and many times not. And we would say that, hey, surgery is not a cure-all, but it's kind of in the mentality of a lot of people. They think, okay, I'm going to try everything, but it's really going to take surgery to get me better. But I really saw the opposite end of that. And surgery is not a cure all. It doesn't get you to 100%. It's not the end answer. So I was really motivated to say, is there a gap in healthcare that I can kind of sink my teeth into and dig in with my curiosity and find different things I can help people in my own family, people I know, patients of mine that don't need to go all the way into the most invasive method. So that was the mindset. And then when I was going through my schooling at National, I had a big focus in sports med. I helped run a sports rehab club and got really into that. But it's a popular topic, and when I was getting out, a lot of people wanted to get into sports chiropractic, and it's hard to define exactly what that is. But I thought it was kind of a crowded space, and nobody was talking about focusing on chronic pain. So from a business advantage, I think that allowed me to niche down and focus on something that was both needed and wasn't a crowded space. Still isn't a crowded space, in my opinion.
Right. So obviously, this grip approach evolved over time.
hmm
Kind of in a nutshell, what is it, and how did it develop in your practice? I'm assuming it was a process. Is it still a work in progress, or
Yeah, I think it'll always I think it'll always be a work in progress,
that's
like
what we
like
call the
most good
practice
things
then?
are. Yeah, yeah. In all honesty, it started developing when I was a student. In fact, it started developing really before I even got into chiropractic school. I'm a big processes guy. I like to be creative, but I realize that if you want the freedom to be creative, you have to have a really good foundation to kind of run forward with, so that you can be creative around some hard facts. So just my approach to learning, I was always looking, what can we systematize or consider an almost factual thing to build creative solutions onto. So going through chiropractic school, I was looking at all the different things I was learning. At National, they dig a little deeper into the physical examination and some general health conditions that than some programs do. So if we're doing evaluation of the viscera or the digestive system, and then in another class we're doing an evaluation with orthopedic testing of SI joint and back. My question is, how do I go into one testing system versus the other? And maybe is there a unified way that I can test and look at multiple viewpoints and get maybe a more streamlined, actionable answer? So that was the initial concept. And when I started digging into other post-grad work like dynamic neuromuscular stabilization, a local American physical therapy group does postural restoration as to a PRI. I dug into that. One of my mentors here in Chicago, Robert Lardner, also co-wrote a book called The Yanda Approach. I dug into that. And I was really looking, where do all of these systems that are good on their own kind of agree on the language and the methodology of what should happen? And can I make a unified way to do one test versus having to test in all three different systems and follow three different plans with that? Just kind of bring it together into a streamlined view. So that's the origin of it. But when I describe it to chiropractors, usually the best way to think about it is chiropractors are experts at palpating the spine and joints, or they should be experts at palpating the spine in three planes of motion, identifying a restriction in movement, and then introducing an intervention to restore that restriction. And grip approach does that same thing, but instead of being hands-on with the patient palpating, we're essentially asking the patient or palpating their motor control of those movements. So where I might by hand, palpate neck motion, I'm going to give my patient a specific test that doesn't require me to be hands-on, have them go through the motion, and then I can measure and grade their motor control. And I'm using that pretty high up in my hierarchy of testing to determine which interventions I'm going to pair. So when
Right.
a chiropractor goes through our training, they'll still assess the spine in three planes of motion by hand, but they might do that with motor control testing first, and then they'll be able to plug in an exact tissue therapy, whether it's by hand, dry needling, shockwave, instrument assisted, whatever it may be. They'll be able to plug in the best rehab strategy that I've been able to borrow or develop to address that, and they'll kind of know where to be most effective applying their adjustments.
Got it. So, this story kind of reminds me of, I don't know if you've ever heard of the EOS system, the Entrepreneurial
Yeah, we
Operating
use
System.
it.
Well, we do as well. My company has run on that, and my practice did for, geez, over 10, 12, 15 years now. And the story is so similar, about Gino Wickman, the guy that wrote the book Traction. He went out and learned everything from all the influencers that were out there, and then condensed it into the EOS model. And it
Mhm.
sounds like you've kind of taken the best of all the things that you've learned and combined it into basically an operating system, lack of a better word, to assess patients. So when you do these assessments, and I guess you arrive at a diagnosis like all of us would,
Mhm.
um, what makes the system different from just traditional rehab frameworks?
Yeah, great question. I think a lot of rehab frameworks in their ideology, they want to get to a spot where they're basing decisions off of function rather than off of symptom reporting from the patient. However, most systems struggle to actually take that all the way through the implementation stage. It's a good theory, but it's not really structured to where you can base your decisions purely on function. So often that subjective interviewing comes back in throughout the process. We do a rehab exercise and then we ask, does it feel less uncomfortable to get out of the chair? Or we use a rehab strategy and we ask, are the symptoms radiating further down the leg or closer to the spine? And that's really good subjective information to bring in. But where we differ is that we try to be a purely objective, measurable system. So the patient's subjective reporting is important to me as a person, but it's not super important to me in my clinical mindset. I'm trying to base everything we do purely on, can we get this person to function better in their life and as a human? So I think that's one of the big differentiators in how we go about our business. In addition to that, I think we're very precise with our choices that we make, with respect that we're not going for perfect. We're always going for better, not perfect. But by taking a keener, more precise eye to how we evaluate, we can also be more specific in the way we apply the rehab, communicate it, and have a patient buy into understanding what's going on and what their role in getting better is.
As I listen to this, we've always had the challenge in chiropractic that it works so good that our patients leave sooner than
Mhm.
they probably should.
Mhm.
Um, and it sounds like you've taken the strategy to really take the subjective part off, or out of the. You consider it, but it isn't a driver because, I mean, my God, how many patients have we all had that come in and depending on their pain tolerance, every day is a 10. I'd have these patients go, "Oh, it's a 10, it's a 10." And I
Mhm.
finally asked them one day, I said, "Are you aware that there are other numbers you can pick?" Because in their mind, especially if it's a man, they're all a 10, they
Yeah.
don't go to
Yep.
the doctor unless it's a 10. And, I do see that as a challenge as we evaluate patients. They're looking through their lens and
Mhm.
their history and, um the subjective complaint, like I said, while you have to take it into consideration, if you're just going by a pain scale of whether you're going to continue care or not, we know that that evolves over time, and
Mhm.
some days are not, and it just really I don't think is the strongest measure to determine if care is needed, if it's working, and so I love the approach of let me observe if it's working versus
Mhm.
how you think you're doing versus how you really are because sometimes there's that disconnect between the brain and the body, I think sometimes.
Absolutely. You actually said something interesting earlier about how a lot of chiropractors struggle with patients leaving a little too early in their care plan once they feel better. And I definitely see that as a case, but I would just share from my perspective on the chronic pain recovery My practice, 80% of the patients in my practice have been struggling with their condition for more than 6 months. And I feel like that ratio is probably flipped for most chiropractors. I think most chiropractors see a lot of acute pain in their practice where it's really important to get that under control right away. But on the chronic pain side, in addition to them understanding when their recovery happens, I think if somebody's suffered with something for 6 months or longer, they've started to centralize some of that process, and it's no longer an accurate report that they're getting from their body about what's going on. So, actually getting them to understand function and for them to be able to see and demonstrate change based on function is part of their healing process of letting go of some of that subjective alarm that gets skewed over time.
Well, and if you're training them to focus on how they're functioning versus how they feel,
Hmm.
mentally, it would seem that um, if it's done properly, the patient begins to know when they need to come in because they objectively say, "Wow, I can't do that as well as I did 2 weeks ago.
Hmm.
It's getting to be a problem." So
That's
uh,
right.
that makes a lot of sense. So let's go back to that long phrase that I had a hard time pronouncing earlier, the dynamic neuromuscular stabilization practitioner that you did in Prague. I said praise
Yeah.
here. So I've got depending on how you want to say it, I gave you both. How did that experience influence the way that you do evaluate movement? For those that aren't familiar with that, what exactly is that?
Yeah. I'll summarize it in a really condensed way. The short phrase for that approach is DNS. And in its basics, DNS looks at developmental ontogenesis. So if we look at 1,000 healthy, normal, I shouldn't say normal, well developed nervous system through that first 2 to 4 years of life, we're going to see some pretty similar movement and motor control landmarks as they progress forward. And when the nervous system is developing with some variation of ideal, we might see, hey, this landmark is being missed by a few months, or there's this adverse sign that's starting to show up now. And through some of the founding members of the Prague School of Rehabilitation, some smart physicians started to look at how they could influence that neurological development by holding certain positions and exercising through certain positions to re-engage the nervous system as it developed in a child. And then Pavel Kolaj, who is the founder of DNS and part of that Prague School of Rehabilitation, he kind of helped move that a little further into the adult patient. Say some of these same principles we look at in healthy developing babies and babies who aren't developing in a healthy way, we can apply those same principles to our adult patients. And using some of these foundational positions and exercises, we can access part of the nervous system that is there and has some pattern recognition, but isn't being used currently. And it's a way to kind of light up that part of the nervous system and influence rehabilitation. So that's kind of like a little basic overview of DNS. It's used in pediatric cases, things like cerebral palsy. It's also used in professional sports with tennis players and hockey players. And now, with it being a very globally dispersed program, it's used in PT and chiropractic clinics pretty heavily now as well.
Got it. Well, hang tight while we take a quick break to hear from our sponsors. Welcome back to our podcast with Dr. Ben Fergus. You know, you often evaluate biomechanics for college, professional, and as I understand, even some Olympic
Hmm.
athletes. What are would you say are the most common mechanical issues you see, and what do you think is the one thing that most clinicians consistently overlook? And just kind of as a preface to the question, I would imagine that the things that the mechanical issues you see are really going to vary from sport to sport to sport. So what's your what is the average Cairo overlooking? And it's right there in their office.
Boy, that's such a great question. I wish I had a week to think on it before before we come to an answer.
Hey,
But
we can do a follow up.
no, I'll share a couple things. And this might not be as much of a hidden gem, but I think across all sports that I work with, having free and dynamic control of hip extension is a really vital part of the athletic experience, and for my my average human that needs to get out of their chair and walk around the block. And what we see very often, let's say in your typical chiro patient who's not an Olympic athlete, is they may not be able to extend their hip even to a straight line with their spine. It might be stuck at, -5 or -10 degrees of hip extension. Yet our bodies need that to stand upright. They need it to walk. So we're going to have to steal that from somewhere else. And the easiest place to steal that from is the lumbar spine. And that ends up chewing up and eating into the function of the lumbar spine because we're forcing it to act like an extension movement in every step we take. So that would be the average patient presentation. But in an Olympic athlete or a professional or collegiate athlete, that hip extension is where they get power and speed, and it's tied into hip flexion on the other side. So I think with every athlete that I look at and every patient that comes in, we're always evaluating their control of hip extension. I'd probably focus on that one.
Well, it certainly makes sense. I think in the Cairo Congress meeting where I heard you speak initially, you mentioned or described a model of non-surgical joint replacement through
hmm
functional restoration. Kind of explain what that means and how it changes the outcomes for patients who are probably headed to surgery. So,
Right.
what does
Right.
that
Yeah.
do?
I think this is something I'm probably the most involved in and passionate about today is helping give patients a real alternative to joint replacement surgery. And I'll be frank, I wasn't focused on this at all 3 to 4 years ago. This is a very recent focus for me. Um, I've always seen patients that have had bad knees and bad hips, and they've always said, my doc says it's bone on bone. I'll need surgery eventually, or I'm going to get surgery next year. And I just sort of accepted that, like, okay, they're in the system. They've got a joint replacement plan. They're not seeking my care for that. They're here because their hip hurts, or they're not walking right, or their back's bothering them. But they already have a plan for their knee, and I'm not part of that plan. So probably a lot of us can relate to that. We might have done some palliative care for degenerative knee, but never took on the role of, can we help this patient with restorative care of a degenerative knee? And that was the spark for me to really dig into the research and every available method to see, can we do something that's more than just palliative care for degenerative joint? Can we slow the degeneration? Can we halt the degeneration? Can we create a ecosystem of regeneration in that joint that's been given up on? And to my surprise, initially, there's a lot of really substantial research on what can be done to get out of the catabolic degenerative state and back into the anabolic repair and rebuilding state within joints, especially in grade 1 and 2, a little lesser extent in grade 3. But I'm not ready to give up on those grade 4 degenerative joints either when the ecosystem is available to change. If somebody is completely tipped over the edge, morbidly obese, unwilling or unable to change some dietary and lifestyle factors, is not able to commit the time or energy it takes to recover, surgery most likely will be their best option. But if you take that same grade 4 degeneration, you put it into a relatively healthy adult who has the willingness and ability to change up some dietary and lifestyle factors, dig into the exact things they need to do, a lot of change can happen.
Yeah. And we've all seen this in our practice as well. Even though someone may be headed for surgery, the reality, I mean, and now the term today is prehab.
hmm
go ahead and start exercise. Go ahead and start doing things that will actually make the surgery probably more effective. Because if you go in completely deconditioned, you got muscle atrophy, you've got restriction of range of motion, and you go and you have a surgery. Guess what? They just surgerized the joint. They didn't necessarily do anything for the surrounding tissue, the soft tissues, and you could have a great surgeon and a horrible outcome because of the condition they were in before they went into surgery. So,
Hmm.
from the patient's perspective, whether you eventually head to surgery or not, you're going to be a much better candidate and have probably a much better outcome if you take that approach.
Yeah, I think that's absolutely true, and we see that. We occasionally run this approach on patients that end up getting a joint replacement, and we get a lot of comments from surgeons about how smooth their recovery went, and they attribute it to the work they did beforehand. That's still not our goal with it. Our goal is definitely actually getting the body to trigger replacement of the cells within the joint, but sometimes that is the end outcome, and that can be helpful as well. I think another factor when you consider surgery, especially if somebody's first surgery is going to be a joint surgery, we don't actually know how their body takes to being cut and how their body heals. And if you take somebody who might have an autoimmune disease like lupus and you compare it to somebody who heals really rapidly, their response to any surgery is going to be vastly different. And uh, unfortunately, it takes getting a surgery to learn how your individual body is going to respond to it, no matter what the stats are on the surgery. Some people lay down a lot of keloid material and scar material. Some people, it looks like they've never had an incision, and we don't really get to know that ahead of time.
Boy, wouldn't that be an interesting thing to figure out?
Hmm.
So, in your years of practice, I like asking docs in the audience whenever I'm lecturing, can you remember your most favorite day in practice or a case that you can't even believe got better? And I mean, you're on the fence about whether you can help them or not. What's your one of your favorite patient stories?
I could share two from the past 5 years or so that are pretty straightforward. There's different reasons why they were neat for me. The first, I'll share a story of a collegiate athlete that I worked with for multiple years. He came into the program as a undersized walk-on in the linebacker position, and he was referred to me for pretty significant, severe hip impingement and labral issues. And he had tears in his labrum, he had tears in his quadriceps, and I would put him up there with the stiffest hip I've ever seen. And he said, I have one shot. I'm a walk on. If I get surgery and sit out, my shot is basically gone at that point. And I want to do everything I can to make the team, stay on the team, and not have to have operation on my hip. And just like we think with degenerative joints, we think of labral tears, or that's most likely a referral to an orthopedic surgeon. He had already consulted with the orthopedist. He knew what they wanted to do, and he was asking the question, what can you do? Is there anything we can do together that's not the surgical option? So we did some goal setting. He had big goals. He's an undersized walk on. His goal was become a starter. And then his bigger goal beyond that was to lead the nation in tackles. So this is obviously a highly motivated
No
individual.
doubt.
And we got to work.
That are delusional.
Potentially. So, but this is why it led to one of my coolest experiences, my coolest days in office. So we started working on the hip. We got his hip range of motion improved. It started at 0 degrees of internal rotation, and we were able to improve his hip internal rotation to over 30 degrees, doing just rehabilitative techniques. I worked with him throughout his collegiate experience, both from like my chiropractic hat, my rehab hat, but I also took on a role of a performance coach a little bit. Our sessions would always include something that went beyond the clinic door and into the gym that we have in our facility, and we'd kind of ramp things up and monitor his progress. So over the few years we worked with him, he became a starter. He had won a bunch of awards as a Big Ten player, and in his final year, he actually led the nation in tackles
No kidding.
for NCAA Division One. So he hit all of his goals, and I think the most rewarding day in practice was he came in with his two placards, one for the most solo tackles and one for the most total tackles, and took a picture with me the day before he moved out of town. So I think that was really impactful. It showed the role that we can take in helping athletes, not just in a small window of a week or two, but in kind of a landscape view of year over year, what we were able to accomplish together. So that was a big one.
So that really was a significant game changer for him.
It was.
And
It
you know
was.
what's really neat. Again, we've all seen it in practice. Is you help somebody like that, and um, you see them years later, and they tell the story. Doc saved my life or saved me from
Yeah.
back surgery. While it may be routine to us to get positive outcomes for a lot of patients, it's like, holy cow, I can't believe they were able to help me with that. And they really, really were
Mm-hmm.
strong advocates for your practice and just for the profession in general. So I know you train clinicians, and that
Hmm.
includes PTs. I'm assuming athletic trainers on
Hmm.
exam, rehab, sports injury. Um, what gaps do you consistently see in healthcare education? I'm not talking about just in chiropractic, but maybe the people you've trained from PT and from athletic trainers. What's the big gap that you see, and how does grip really help solve that?
I think that the biggest gap that I notice across all professions is that most providers are drowning in a sea of good tools without a clear framework of how and when to apply them. And that's really the problem that we help to solve is we make the tests you already use, like orthopedic testing, more meaningful because we show you the action plan that should be tied to that orthopedic test. And we give your tools higher effectiveness because we plug them into a system where you know exactly how to apply it, when to apply it, how to dose it, and what your patient needs to do on their own. So it takes the stuff you're already good at, gives it structure and a framework for you to go from good to great.
Awesome. So if doctors want to know more about the grip approach, where do they start? Is this a web-based program? Is it a in-person or a combination thereof?
Yeah, we have a lot of options for that. So our website is gripapproach.com, GRIP, gripapproach.com. A couple ways that people can interact. Right on that website, there is a free 4-hour course. And that's an online module only. It goes through some of the foundational pieces of what actually makes up a grip approach. It includes a couple assessments and treatment strategies at the end of that course that are foundational material, and it lets you kind of dip your toes in and understand what we're trying to accomplish. So that's free for everybody. I wouldn't hesitate in signing up for that. You can probably get some CEUs based on your profession or your state with that free course. In education, I believe if you're going to be working in a face-to-face position, you need face-to-face training to be really good at it. So I'm always going to emphasize our live in-person classes, which we do both at conventions and regionally here in the States and abroad. But I also know after attending a lot of live classes that knowledge sometimes goes in one ear and out the other when you try to reclaim it and use it. So we build a pretty robust virtual companion course to all of our classes that is meant to help you with your recall before and after taking a class. So all of those options are available on gripapproach.com, in person, virtual only, and the blend.
Got it. You know, one of the gaps that I have felt like for years now, I've talked about it for the longest time in our training in chiropractic colleges, is unfortunately when we look at the patient population that goes into a college clinic,
Hmm.
as I've said, I don't think we get a real patient experience because I don't know how it was at your school, but typically we're seeing patients that are well and handed
Hmm.
down from the trimester before or the
Hmm.
try before. And the type of patient that we would see, and this had been a number of years ago, really wasn't a typical patient. It wasn't real world experience. Fast forward, I started the chiropractic program at the VA Medical Center here in Mississippi, and what I saw with the students that were doing rotations through all the different departments, including the chiro, was in our world, we're going to read and study about diabetic neuropathy. In
Mhm.
their world, they say, "Let's go up to the third floor. Let me show you what it looks like." And I wish I could wave a magic wand and really give our students a more real world
Mhm.
exposure to actual patients with real problems. And again, I know that's not across the board at all of the schools, but at most of them, we've got this model, and so I was really excited to be at the to do that VA program for about 4 years because I
Mhm.
learned so much
Yeah.
from all the other instructors, all the other medical doctors in that integrated environment, and quite frankly, it was the best thing I ever did for my practice because I mean, we got referrals from after I was there for those 4 years. I got referrals from doctors I didn't even know who they were, but they were students that were going through a rotation and they saw their neurosurgeon mentor or orthopedic mentor working with and referring to a chiropractor. And so it all, what you do in school, you tend to do when you get out of school. Well, if there's
Mhm.
no interaction with chiropractic during your training, we're not even on the radar
Mhm.
to consider utilizing. So, hopefully we do see that continuing trend of exposure again, not so we can be like them or they can be like us.
Mhm.
The reality is the medical world sees about 80% of the population with neuromuscular skeletal problems that we can help. And so they have this wonderful resource and tool that they don't even know they have.
Mhm.
I'd really love to see that change in over time to where students, whether it's through that type of activity in a institution or hospital or VA center, or whether it is, and I know schools are doing this, or whether it's them getting assigned to a practitioner and working in the field while they're also in school. I just think we get a lot better clinical exposure and clinical experience if we kind of gravitated to that. So anyway, I'm the world's foremost expert on my opinion, and that's my opinion.
I like your opinion. I feel strongly about that as well. We've always run a strong preceptorship program in our clinic. With a lot of different schools, not just locally. We've recently had a few students from National, but prior to that, with Logan and Northwestern, and we try to talk with students at all the schools to whether it's with my clinic or somebody else's. It's really an advantage for them to get out of the school, get into a different practice, whether they're only shadowing or if they can do something like a preceptorship and get those more real world reps. But also, part of what you said really resonated with me in this idea that in healthcare, we all professions often take this perspective of it's me versus them. Like this is the way I do it, that's the way they do it, and it's in conflict. And sometimes it is in conflict. I personally really have a conflict with the overuse of corticosteroid injections. And there's two ways to look at that. There's a way to say like, hey, I can bully on this medical doctor that overuses corticosteroid injections, or I can try to go into his office and shadow and learn why he's using corticosteroid injections in that way and open up a dialogue and say, here's what we would do in that case. And here's a study that I'm looking at that talks about what happens when you use more than this dose of corticosteroid injections. What are your thoughts on that? How do you weigh the decision making, and what are your alternatives? Can we be one of those alternatives when that corticosteroid injection is not right for your patient? So I think having that open dialogue and more of like a partnership idea
Mhm.
is really impactful.
Well, I'll share this with you. I sold my practice in 2020, but my practice was part of a spine center, 6 neurosurgeons,
Mhm.
orthopedic surgery, physical medicine, rehab, PT, OT. And the reason that my practice evolved to that type of practice is because I took the attitude that you took. When I had doctors that wouldn't refer or wouldn't release records, I mean, you can pound your fist and cuss and get all upset with them, but the problem with that is that leaves them owning the problem versus it's my problem that they don't know about it, and they're not gonna just walk into my office, so I've gotta start walking into theirs and doing what you were talking about. And I'll never forget when I first started interacting more with the medical profession, I got this referral from a doc. I hadn't seen one of his patients before, and on the script it said, "Referral to chiropractic, 1 visit, no manipulation."
Yep.
And again, I coulda had a temper tantrum, "Oh, you idiot, what the hell are you thinking?"
Yeah.
I coulda gone down that path, but I thought, "I admire this doc for taking a chance and
Mhm.
doing something he's not clearly not comfortable doing,
Mhm.
doesn't know what normal looks like in treatment." And so, I got him on the phone, I said, "Doc, I really appreciate the referral." I said, "You know, Mr. So and so's got pretty severe degenerative, uh, joint disease and cervical spine." And I said, "Looking at your referral, and it's for 1 visit and no manipulation. So you do know I'm a chiropractor, right?" "Yeah, yeah, Ray, yeah." I said, "Well, what is it exactly that you would like me to do for this gentleman?" Because you kinda got my hands tied. So anyway, he said, "Oh, hell, I don't know what you guys do, just fix him." I mean, literally, that was the extent of the conversation.
Okay. Yeah.
And so from that point forward, you take a doc like that who is at least willing to send somebody to you for a trial period of time or
Mhm.
whatever, and then you start communicating with them. You send them an initial report, a couple of weeks later, an update, and when you discharge, an update. And all of a sudden, you're functioning like the specialist that they're used to interacting with. If they refer a patient to us and they never hear from us again, they look
Mhm.
at that as, "I just lost that patient." And so, I really think it's critical for those that wanna play in that sandbox to understand how communication occurs in that world, and
Mhm.
then, again, not to imitate them, but that's kind of standard operating procedure. And if
Mhm.
you're expecting someone from the medical world to, um, to veer from what their SOP is, it's just probably not gonna happen. So, those were probably 2 of the biggest takeaways that I had from being at the VA, seeing how they operate, and then how do I take that experience and plug it into my practice, and quite frankly, that's exactly what happened to where I got invited to be a partner in the development of the spine center. It didn't happen by chance. It didn't happen by sitting in my office and not interacting with others. Sometimes you just, as what is it? Steve Harvey says, sometimes you just got to take a leap. So I encourage you docs, take a leap, expand your practice.
Mhm.
It's a lot of fun doing it that way. So
That's
I got
right.
a just for fun question for you. A couple of who's your hero and why?
Oh, you're bringing the good ones. Hero. Hmm. I really have not thought about that question. That's really interesting. Hero.
We can come back to it, or you can send it to me in the email.
I might have to come back to that one. That's a big question to ask in a quick format.
Yeah. What talent do you have that most people don't know about?
Uh, most people that are in my close circle would identify cooking as one of my talents. It's been borderline an obsession of mine to be very good at cooking.
That's awesome. What's the worst job you ever had?
When I was 13, I believe, in Michigan, there were can and bottle returns. You take your cans and bottles back, and you get 10 cents at the register. My job was to open up garbage bags filled of mostly empty cans and sort them into the companies that we had to return them to, count them out, and write the ticket to give the refund back.
What a great motivation to go to college.
That's right.
Well, thanks for spending some time with us today. I really appreciate it. And thank you all for listening to the ChiroSphere podcast. Please subscribe and share the podcast with your friends and let us know who you'd like to hear from in the future, what topics you'd like us to cover, and we'll do our best to deliver. Doctors, if you're offering discounts of any kind in your office, you need to make sure you're not breaking state and federal rules and regulations on dual fee schedules, inducements, and any kickback violations, which can lead to serious fines and penalties. ChiroHealth USA can help eliminate these concerns by using our profitable discount strategy, which ensures that discounts you offer are 100% compliant and, most importantly, profitable. It all starts with a no cost, no obligation phone call to find out if we can help you, like thousands of other doctors nationwide. Many of our doctors have seen a 20% increase in their revenue and a 50% retention of patients who are part of our network. Over the past 18 years, over 7,000 chiropractors have helped over 4.3 million patient family members get the care they need at a cost they can afford. If you want to increase revenue, retention, and practice with more peace of mind, call us at 888-719-9990 or visit our website at chusa.com, that's CHUSA.com, to find out why ChiroHealth USA is the network that works for chiropractic in you. Thanks so much, Dr. Ben.
Thank you. Appreciate it.